Blood Bank Guy Essentials 012.
And what they found is just exactly what I told you, that there is an increased risk of intraventricular hemorrhage, which was the main outcome they looked at. Mm-hmm. But platelet transfusion did not reduce that risk.
Yes, say that again, Cassandra.
Radiation does not get rid of CMV.
Hi, everyone. Welcome to Blood Bank Guy Essentials, episode 012. My name is Joe Chaffin. I continue to be your host. I do want to thank you. This episode was slightly delayed due to some issues that are not worth discussing, but I appreciate your patience on this one. I am going to keep this introduction really short today because I have a ton to discuss with my guest, who is Dr. Cassandra Josephson from Emory University in Atlanta. And Cassandra is an amazing pediatric transfusion medicine specialist who has done just so much. You may not know her name. If you're around transfusion medicine, you certainly would, but you've certainly read some of her work if you've ever read the neonatal and pediatric transfusion chapter in the AABB technical manual. She's a co-author on the current edition, has been primary author on previous editions. She's done so much and has so much to share with us today, so I don't want to take up really any more time in this introduction. However, Dr. Josephson did want me to let all of you know before we start that she does serve as a consultant for several companies, including Immucor, Octapharma, and Biomet Zimmer. Today's episode is a little bit longer than normal, but I hope you'll stay with me because there's a lot of great stuff to share. So here we go. Here's my conversation with Dr. Cassandra Josephson on pediatric transfusion. Okay, hi everyone. Welcome to the Blood Bank Guy Essentials podcast. I am super excited to welcome to the podcast today Dr. Cassandra Josephson from Emory University. Cassandra, welcome to the podcast.
Thank you, Joe.
It is so great to have you here. I have to tell people a little bit about you, and honestly, if any of you out there don't know something about Cassandra Josephson, you're living in a rock somewhere, because my goodness, she is really one of the giants in our industry today. She's doing so much. She has one of the most unusual combinations of certifications that you will ever find in blood banking transfusion medicine. She's one of the few people in this country that are trained in not only pediatrics, but also pediatric hem-onc, as well as blood banking transfusion medicine. Cassandra has done so much in terms of publishing, in terms of research, in terms of her work with pediatric transfusion medicine, and that's what we're going to talk about today. Just a little bit about her. She graduated from the University of South Florida College of Medicine, did her pediatric residency in a place that I know and love, the University of Colorado Health Sciences Center and Children's Hospital in Denver. I was in Denver area for about 13 years, Cassandra. I don't think we've ever talked about that.
No,
actually.
That's funny.
Yep. She did her pediatric hem-onc fellowship at Emory and also her transfusion medicine fellowship at Emory. And she's boarded in all three of the areas of specialty that I mentioned: blood banking, transfusion medicine, pediatric hem-onc, and stem cell transplant, as well as in pediatrics. She's currently a professor in the Department of Pathology and Lab Medicine at Emory, as well as a professor in the Department of Pediatrics at Emory. Now, I'm exhausted, Cassandra. I don't know how you can keep up with it all. Well, go ahead. I'm sorry. I didn't mean to interrupt.
No. Go ahead. You're fine.
So I'm curious, with all that being said, you're someone obviously who has a really unique background in transfusion medicine, different than most of the people that I speak with about this. But I'm still really curious to know, what was it about transfusion medicine, or what was it in your when you were training in pediatrics and pediatric hematology oncology? What drew you to this particular subset and this particular area of medicine?
Well, that's a very interesting question, because I didn't really know that it was an option to be doing transfusion medicine when I became a pediatrician. Even when I started my pediatric hematology and oncology fellowship, I actually was on course to be a hemostasis and hemophilia doctor. So Marilyn Mako Johnson did research with her and Rochelle Nuss out in Denver, and then came to work with Pete Lawler and Tom Abshire doing hemophilia at Emory. Mm-hmm. And after I got into it and kind of was doing more basic science with mice and things like that, I said, I really would rather be, working with patients more and doing more consultative coagulation, as well as transfusion. And so Chris Hillier was at Emory University at the time, and he had the fellowship. And so Tom Abshire said, hey, why don't you look into that, since that's where you think you want the direction of your career to be more clinically related and clinical research oriented. And so after speaking with him, it seemed like the right fit. And so that's how I kind of gravitated towards that. It's an interesting thing because like I said, didn't even know it existed.
Well, and I think what you're saying is interesting in many ways, but I think that, well, put it this way: you and some other folks have published some work describing somewhat of the, I don't want to say the paucity of researchers and workers in pediatric transfusion medicine, but I think that there's a real need out there for more young folks coming up that are trying to, maybe people that are in the track that you were in, pediatrics and pediatric hemonc, to consider working in transfusion medicine, because there's a lot of work still to be done, isn't there?
Absolutely. So I'm the fellowship director at Emory University, but in the pathology department, but I also have a pediatric transfusion medicine fellowship that I developed out of a KO7 grant that was put out by NHLBI. Oh, wow. And they really wanted the encouragement of more people going into pediatric transfusion medicine. There was really an attrition of people. And the questions that need to be answered are many. Almost everything we do is not evidence-based. It's extrapolated from adults. And so you are right on. The other thing is that you can be an anesthesiologist, you can be internal medicine, you can be a pediatrician. You don't have to even be hemonc to be able to go into become board certified in transfusion. So pathology, which was the traditional way to go into transfusion medicine, is not the only path now. And that's been around for quite a while. So the more I can get the word out there, the more we encourage people to go into pediatric transfusion medicine.
Boy, absolutely. I'm really glad you said that, because I don't think that's as widely appreciated as it should be, that the American Board of Pathology has opened things up in recent years for non-pathologists. And I'm a pathologist, so I can speak that heresy. It's totally, I mean, I love it. Honestly, I love working with transfusion medicine physicians that get the clinical side of things. I spend a little bit of time as a clinician, or not a lot, but enough that I appreciate the clinical side of things. And I think that sometimes I love my pathology brethren. They're awesome. But sometimes if all you've done is pathology, it's a little bit harder to understand the clinical side of things.
Well, I think there's a good complement between everybody. The more there are from both disciplines coming into transfusion medicine, I think there's a big complement. I work in a department that has, is made up of both types of tracks, both adult internal medicine going into transfusion, as well as CP or APCP trained, and then pediatric hemonc. So it's really nice to have different, diverse backgrounds of training.
Yeah, that's the key.
Enhances the field.
Agreed. That's the key. I certainly didn't mean to slam my pathology brethren.
No, I didn't think you were, but I think that it's kind of nice to have all of it and not just from one angle. Yeah.
Well, you used a phrase just a couple moments ago that I think is the biggest reason that I wanted to talk to you and talk about our topic today, which is the top 5 things that we want you to know about pediatric transfusion medicine. And so just a few moments ago, you used the phrase extrapolated from adults. And I wrote it down when you said it, because that's it in a nutshell, isn't it? I mean, I think that I will freely admit to you that, having spent my entire career taking care of adults in terms of transfusion medicine, and not a lot of time in hospitals doing a ton of peds, we have way too much that we're assuming is true in pediatric patients, and not enough that we've proven. And that's what I hope that we're going to explore today.
Absolutely. And that's why I picked the topics that I did, because you can kind of see where things have grown and changed, but how things I'm going to contrast some of what we have found now that is in sharp contrast to what people sort of thought with regard to some of these topics. So that's why I picked them particularly.
Terrific. Well, let's do it. Let's rock and roll with this then. So the top 5 things you should know about pediatric transfusion today. Cassandra, why don't you hit us with number 1? What's number 1?
Okay, the volumes vary. So this actually pertains to total blood volumes and plasma volumes of pediatric patients, neonatal patients. And I bring it up because especially with neonates or even up to the age of, let's say, 5 years, these total blood volumes are much smaller than adults. And interestingly enough, we have quite a bit of trauma in Atlanta, where I'm located, and we have level 1 trauma and level 2 trauma centers at both of the freestanding children's hospitals that I'm in charge of the blood banks for, and so we have set up algorithms to kind of fit what those patients have. And the importance of that is that 1 unit of red cells, let's say, can range between 250 mLs to 320, depending upon what the anticoagulated preservative solution, CPDA1 versus AS1, for instance. And if you think about a child who's 2 kilos and you use 80 to 100 mLs per kilo as the total blood volume, right then you get to 200 mLs is their total blood volume.
Right.
And their plasma volume is only about 80 mLs if you use 40 mLs per kilo as a rule of thumb. And so what ends up happening is that in many places that want to resuscitate a patient, they will just pour red cells into them, and a whole unit of red cells immediately is their entire total blood volume. And some of these places forget that we don't transfuse whole blood, so it's missing all the coagulation factors.
Right.
And the patient's already bleeding, and then they just dilute out the rest of what's there. And before you know it, you have dilutional thrombocytopenia. Basically, you have like no platelets, and you have no fibrinogen or coag factors. And so I want to emphasize the point is that what's really challenging about children is that they are all different sizes. You can't just say, 70 mLs per kilo. And, if you're a woman, you're 45 to 70 mLs per kilo, and that's it. And so we've done some special things to kind of combat this, or actually to complement what has been found in the adult literature when it comes to trauma specifically, because we are all kind of familiar with that 1-to-1-to-1 ratio of red cells to platelets to plasma. And we want to be able to try to emulate that for children. And so what we've done, and we've published this both in Transfusion as well as in the Journal of Pediatrics, is trying to show that coagulopathy is a problem just like it is in adults when you have trauma. So, and it leads to morbidity and mortality. But we also wanted to show feasibility that there are algorithms that can be done by your blood bank that fit different size groups, like 1 to 5 kilos, 6 to 10 kilos, etc. And that way you can have packages that kind of look like the proper study or things in the adult world. You can kind of see how that's been scaled back with all the different blood products to be delivered in the right ratios for the right weight. And that was all based on the fact that these patients have smaller total blood volumes and smaller plasma volumes.
So practically speaking, Cassandra, how that's obviously we could get really deep into the weeds there, but just kind of keeping it practical. How does a blood bank even consider setting up something like that?
Well, basically, we have it worked. First of all, we've met with the trauma surgeons. We've met with everybody, and we have a whole team, anesthesiologists, nurses. We have runners. We have it all coordinated. The next thing we had to do was we had to have the ability to make these units quickly. And so we do have thawed AB plasma on the shelf.
Right.
We do have cryo packages that are already pooled, that are smaller, like pools of 2.
Right.
Pools of 5. And then we actually just make small aliquots at the time, because red cells and plasma are in the first package, so we can get that out and then start getting the platelets done. So we have to have enough people in the blood bank to be able to do it, but we also kind of do a huddle and kind of, as soon as we get the trauma beeper going and it's a massive transfusion, we start rocking and rolling. And they communicate to us the weight of the patient by what their guesstimation is, and that gets us rolling on that as well.
Well, so I mean, it sounds like what I always tell people with adult massive transfusion is that the majority of your work is actually done before the event happens. You have to lay the groundwork and be ready for stuff like that. Otherwise, if you're trying to figure it out on the fly, you're dead.
Absolutely. And one of the things we try to do is even before they've hit the door, we're trying to know what's going on with the patient. So that's how early the communication is. And as soon as they can get a specimen, we will even give type specific, it doesn't even have to be cross-match compatible, because we try to get away from the O's and the ABE plasma as quickly as possible, because inventory-wise, we're not in a large hospital that always has all of the O inventory.
Of course.
So we have to give O's to other patients within the hospital who are O. And so we're very, very cautious about not using all of our O inventory as well.
That's fantastic. And that's, so you mentioned that you've done some publishing on this, and what's kind of your, I guess my feeling with adults is that the 1:1:1, while it's widely accepted, that ratio of red cells, plasma and platelets, kind of, sort of, if you're talking about whole blood derived platelets, I should say. But anyway, there is still a little bit of controversy with that in the adult field. Studies that are being interpreted slightly different ways, and a little bit of controversy. How do you feel about that in your population?
Well, I got to say that we did two studies. One was we looked at coagulopathy. This is in the Journal of Pediatrics, Hendrickson et al. 2012. And basically, we looked at 102 of our patients before we did any resuscitation. So we looked at their PT, PTT, fibrinogen, and platelet counts up front, and found that PT, PTT, and platelet count were all statistically significantly bad news if they were they were abnormal, that for morbidity and mortality. So we knew up front that there were problems, and there's coagulopathy. We also knew that many of these patients had fibrinogens that were less than 100 and many less than 60 mLs per per deciliter. And so milligrams per deciliter. Sorry. And so what happened is, those were the greatest, were at the greatest risk for mortality. And so we understood that coagulopathy exists like it does in adults. Then the next question was whether these algorithms really work. And really we haven't had enough patients to show this 1:1:1 ratio, because we just can't get the numbers yet. This is a single center R's. We're actually looking at an NIH grant with WashU and Phil Spinella and Nationwide Children's, et cetera, trying to get the numbers bigger so we can actually demonstrate some benefit. One benefit we do have having the algorithm is that we know that we're keeping up with the resuscitation, meaning that they're not falling so far behind with their coagulopathy. We just don't know if it's the 30-day mortality is improved and the later mortality is improved in a similar fashion to the way the adult literature is showing. We have found that we had to move up our cryoprecipitate, which is basically our fibrinogen arm. We've had to move it up to the second package. We usually started it in the third, because we are getting coags in the middle of our MTP protocol. And we were seeing that we really weren't compensating enough for the amount of consumptive coagulopathy that's occurring from the trauma. So there may be a slight difference in the consumption of fibrinogen in children than in adults, and especially if they're very small children, because protein C and protein S are way lower until you're about 12 years old. So there may be some hemostatic differences that are playing a role in this coagulopathy. So jury's not out yet.
That's awesome. So since we've got a lot to cover, let's just kind of summarize that. So the first of the top 5 things that we need to know is that the volumes vary, and you mentioned your discussion of pediatric and neonatal plasma volumes and how that relates not only to regular transfusion, but primarily we talked about massive transfusion and dilutional coagulopathy. Is there anything else you want to say about that one before we move on?
I do, and it is about out-of-group plasma.
Go.
So in adults, it seems like it's permissive to give out-of-group ABO and out-of-group plasma at around a liter of it, and I actually disagree with that. But at least if you're giving it in an adult who weighs 70 mLs, they have quite a big plasma volume, still using that 40 mL. So you got like 2,800, blah blah blah.
Right.
But I think when you get to these smaller blood volumes, if you give a O platelet, let's say, to an A individual and they weigh 15 kilos, and we don't know what our O's have as far as an anti-A titer, because they're all over the map and we don't measure it in the United States, then there is a possibility of causing a hemolytic transfusion reaction. And in 2004 or 2005, there was a pediatric death reported when there was out-of-group platelets given, an entire apheresis platelet given to a patient. And so I think this has to be remembered when we're giving out-of-group plasma to children, that I discourage that, and we should wash or volume reduce if that need be.
Okay, that's awesome. So that is topic one of the top 5 things that you should know about pediatric transfusion. The volumes vary. So Cassandra, let's move on. What is number 2?
Number 2 is predicting platelet effect in neonates and pediatric oncology and hematopoietic stem cell transplant patients. And I know that sounds like a really big mouthful, but really platelet effect and actually bleeding risk are so important and really are very different than adults in both neonates and children. But there are some similarities between the neonates and the children, not complete similarities, but I think since we're talking about this, and I think it's very, very different than adults, I thought it was worthwhile, and there's new literature out about both of these areas, so I thought it was something to mention.
Yeah, cool. Let's go.
So thrombocytopenia, it's associated in both neonates, and I mean very low birth weight and extremely low birth weight infants that weigh less than 1,500 and less than 1,000 grams. Those are the babies I'm talking about. And then in those peds, oncology, and transplant patients, thrombocytopenia has been associated with an increased risk of bleeding. That's known. The question is giving platelets going to do something about that risk? And it doesn't seem like in either one of these newer publications that it is going to do anything, that really the severity or the degree of thrombocytopenia does not influence both intraventricular hemorrhage, which is the main bleeding outcome they worry about in these very, very, very small babies. And it doesn't seem to change the bleeding outcomes in patients who have hyperproliferative thrombocytopenia secondary to chemotherapy. As far as if they have a 10,000 platelet count or if they have a 50,000 platelet count, the range of platelet count and the thrombocytopenia, it doesn't matter if you give platelets, they seem to have an increased bleeding risk. Giving platelets doesn't change that bleeding risk. Wow. And that's a really big deal. Okay. Yes. Because most people, and in the blood banking world, platelets are like, that's all they think about in hemostasis. When the newer study that just came out, and I'm talking May 2016, like this month, it was just published in JAMA Pediatrics. And we were a part of it. It was a retrospective study of, it was 6 centers in the United States. We looked at platelet transfusions from 2006 to 2008 and all the NICUs that were involved. And Martha Sola at Boston Children's was the senior author. There were over 900 kids, almost 1,000 kids looked at, and they were around a gestational age of 28 weeks. And there were over 1,000 transfusions given to all these babies. There was about 4.5 plus or minus 6 platelets transfusions per baby given. And what they found is just exactly what I told you, that there is an increase risk of intraventricular hemorrhage, which was the main outcome they looked at. But platelet transfusion did not reduce that risk.
That's stunning.
It is. It's huge. And the hazard ratio there was 0.92. Like it didn't reduce it at all. Yeah. And so, this is very important because, in the United States, platelet transfusions, and this is shown in this paper, and we actually wrote a survey in 2009, Dr. Sola and I, which was in pediatrics, and it showed that people are transfusing in the United States for platelet counts greater than 50,000, not just in the first 7 days of life of these babies, but even older. And in Europe, they go much lower. There still has only been one randomized control trial showing 50,000 versus 150,000, which is where the 50,000 mark comes from, that Maureen Andrews did in the late 80s, early 90s. And they showed no difference in intraventricular hemorrhage with that randomized control trial, which was with a very small amount of patients, like 100 patients. So we're geared up right now that we need, because retrospective studies still are wrought with bias and problems. We really need right now a randomized control trial in the United States in this age group. So we don't have that definitive trial yet, but we have data now for that. But I just want to underscore that platelet transfusions are not going to solve this problem of bleeding still. But an intraventricular hemorrhage probably has other pathophysiologic mechanisms of why it's happening, and we aren't stopping it by giving more platelets. That leads into a similar finding that we found in the secondary analysis of the Plato study, which was the platelet dosing trial that was done, and it was in the New England Journal of Medicine in 2010, with Cheryl Schlichter as lead author, and so we did a sub-analysis of all the children, and there were around 200 children who were analyzed in that sub-analysis, and what we did find, similarly to the neonates, is that the platelet count did not predict, even though there was thrombocytopenia, this is everywhere from a 5,000 to an 80,000 platelet count, it didn't predict grade 2 or higher bleeding in these patients with cancer or autologous or allogeneic stem cell transplant. But children bled a lot more than adults at the same wide range of platelet counts, which was a shocker to the adult treaters. Another shocker to the adult treaters, and another contrary finding to the New England Journal of Medicine article, which we published our findings in Blood, is that, because I was the lead author in that, and so the findings there showed that autologous stem cell transplant patients who are usually 0 to 5 years of age bled 90% of the time, no matter what platelet dose they got. Platelet dose didn't matter, just like in the big study, but they got autologous stem cell transplants, and they bled more than the autologous stem cell transplant adult patients who were more like multiple myeloma patients.
So when you say bleeding, Cassandra, you're just referring to grade 2 bleeding?
No, grade 2 or higher. It could be grade 3, grade 4. Yeah, it could be.
But not necessarily intracranial hemorrhage.
No. Now, okay. I'm sorry, I didn't mean to confuse. Yeah, the intracranial would be like in the grade 4 level for an adult.
Gotcha.
Or a peds.
I'm easily confused.
No, not you. I might be talking too fast, so I apologize.
It's okay. No, you're fine.
No, in neonates, though, intraventricular hemorrhage and intracranial hemorrhage is the main site of bleeding that is worrisome. That's not the kind of bleeding that they worry as much about. I mean, we do worry about intracranial bleeding, but it's a much less observed phenomena in stem cell transplant and pediatrics and adults. Anyway, but what I was trying to get at is just the bleeding risk. Again, the platelet count, even though both places they have thrombocytopenia, there's still a lot of bleeding going on. And it is unclear why. And even in the same, what you would say, autologous stem cell transplants, children are bleeding at a different rate. They're bleeding quicker. Actually, in the sub-analysis of the kids who had stem cell transplants, the days to bleeding was much quicker than the adults. Like kids 0 to 5 years bled in 3 days, their first bleeding event, even though they were thrombocytopenic. Whereas the 19 and above adults, it took 11 days for them to bleed. 6 to 12-year-olds, it was about 5.5 days, and 13 to 18-year-olds, it was like 6 days. So children bleed quicker when they're thrombocytopenic, but the severity of that thrombocytopenia doesn't predict when that bleeding is going to happen. Another big difference that we found in that study between peds and adults is where the bleeding happens. So it kind of gets to your point with the neonates. Well, in pediatric patients, the kids had more oral and nasal bleeding. So they had more, nosebleeds, epistaxis, and GI bleeding. Whereas adults had more cutaneous and soft tissue bleeding. And that was statistically significantly different in the both, and then the other thing is that kids that were from 0 to 5 and that were between the ages of 13 and 18 as compared to adults who were over 19, when they had hemodynamic instability, it was more seen with the kids actually, which is surprising, with bleeding than the adults. And because kids usually maintain their blood pressure better, even bleeding whenever. But there's something about their vascular integrity, which is kind of one of the things we were thinking about in the discussion of that paper, that seems to be different than the adults. And the big difference between adult and pediatric stem cell transplant, and even the cancers that they have that lead up to transplant, the kids are given a lot more intensive chemotherapy than adults are. Especially, sometimes they even do mini transplants for adults. We don't do anything like that in kids. And so the endothelial cell integrity in the vasculature may in fact be part of why there's so much more bleeding in kids than there seems to be in adults. And that's counterintuitive to what everybody thought. People think, oh, their vasculature is pristine, they don't have atherosclerotic plaques, blah, blah, blah. But I do think it's the way we're treating them that may be at the bottom. I don't know that for sure, but I'm hypothesized that may be why.
So what you're telling me is I have to admit, frightening, because we've got a situation where we've got a whole group of patients from neonates up through pediatric patients that what we have thought traditionally in terms of stuff that we've got on the shelves in the blood bank to help them when they have low platelet counts, turns out it's not going to do a whole lot. So what do people in your scenario, in your situation, people that are taking care of patients, do for those kids that are at risk of bleeding?
I think as far as the neonates go, I think it's a real conundrum right now. I think people are using more plasma, and that hasn't been shown to work as well. And I think people just are now trying to understand that giving platelets might not be the answer. So they don't really know what to do. So I think there is definitely this new study is a platform for more study, not just a platelet transfusion trigger study or threshold study, but actually why or what can we do to combat that kind of bleeding. And neonates have hyporeactive platelets. Their platelets are different than adults and even pediatric platelets. So there's a whole bunch of biology that needs to be figured out there. With regard to the oncology and stem cell transplant pediatric patients, other drugs are being used kind of off-label, and there's some studies going on. There's a study going on right now, the TREAT study in the United States, and also there's a UK study called TREAT, which is looking at Amicar use as a instead of platelet transfusion, or in addition to platelet transfusion, to kind of try to combat the residual bleeding that's going on, and coming at it from the hemostasis, trying to keep the clot in place for a while by interfering with the plasminogen and the fibrinolysis, and kind of stopping that. So I think that people don't really know, but I think they're looking at other ways to do this. I also think that people are working on other measurements of hemostatic function that include platelets. And I know that TAG is out there, but I think we even need better things than that. So I think some novel things are being discussed. They were discussed at the State of the Science meeting in March 2015 by NHLBI. And even there was a pediatric State of the Science meeting this past April. That, again, we need better measurements for, are the platelets working? Is the hemostatic how is the hemostatic system functioning in a patient, and how do we assess that?
That's awesome.
Yeah.
Well, that obviously is a topic we're going to be hearing a whole lot more about, and we should, because that is it has the potential to be revolutionary in terms of how we're thinking about things and how we approach these. So but we have to move on, because we're cruising along. We're doing great, Cassandra. We've got plenty of time. We're okay. No worries, but we got to move on. So topic one was the volumes vary. Topic two was our discussion about predicting the platelet effect in neonates, pediatric hemonc, and stem cell patients, which is shocking. And now we're going to number three. So what is number three?
Number three is called cleaning house. So we're going to look at irradiation and CMV safe products. And I want to just say that I'm going to go quickly through irradiation because there hasn't been a lot of research done recently about it. But people just need to be reminded kind of why we do it. And there are some special cases in children that it really needs to be remembered of what we're doing. So irradiation in general, everybody knows we give 25 centigrade or 25 gray and 2,500 centigrade to reduce the risk of transfusion-associated graft-versus-host disease by cross-linking or deactivating the DNA in the T cells of the blood donor. And if those T cells go into an immunocompromised recipient and they are not deactivated, they are going to cause transfusion-associated graft-versus-host disease. Who are those vulnerable groups? Well, in children, they're kids that have suspected congenital immunodeficiencies. They have SCIDs. They have things that are affecting their T cell immunity. They have DeGeorge syndrome. They're things that aren't necessarily thought about in the adult world. And we also have kids that are getting intrauterine transfusions that we end up taking care of, or they get a neonatal exchange transfusion. And so again, they are at risk of having this happen to them. So irradiating those blood products are important. Hematopoietic stem cell transplant patients, recipients of blood components that are from related blood donors, so directed donation. We're very, very careful about that. And that is a big deal still in pediatrics. Patients receiving HLA-matched cellular blood components, patients with hematologic malignancies, and those specifically with Hodgkin's lymphoma. And then cancer patients undergoing intense chemotherapy or fludarabine use, which has been shown to have patients who can get, who are susceptible to transfusion-associated graft-versus-host disease. I think a group that sort of gets left out are neonates. And that are less than 1,500 or 1,000 grams. You notice I didn't kind of mention them as a group. But really and truly, I believe that the extremely low birth weight, which is less than 1,000, and the very low birth weight, which is less than 1,500, that group really should have irradiation. And the case reports that are out there are in babies that are 720 grams, 25 weeks, 800 grams, 1,500 grams. So, I don't feel like we should play around with that. There are some people who feel like our leukoreduction technology is so wonderful, and it is very, very good with these fourth generation filters, that we're really getting rid of everything. And so why should we even be irradiating? But I always remind everybody that it only takes one. And if it's virulent, if it's, and it's virile and it's able to go, it's gonna make more of itself, and it's gonna take over. And children or neonates develop their immunologic functioning at different rates. And what happens to them in utero and when they're born prematurely, we don't know who's developing what at what rate. We can't even predict who's going to get NEC or who's going to get other morbidities that belong with prematurity. So I don't think we really understand the neonatal immune system enough to play around and say, well, we're just going to take a chance. So I would irradiate that group of units. I've heard other countries have stopped. There are places in other countries just have stopped. And so that's what I would say about irradiation. We do have to be careful with how old the blood is sitting on the shelf if we irradiate a unit, even though there's a 28-day change, or to how, the expiration date, if it's less than 28 days, stays the same if we irradiate the unit. When we let that unit sit on the shelf, we know that it's aging in general, and then we've made it age even worse. And so there is a potassium leak. And I think that there have been plenty of publications of late for pediatric patients that have shown that there are deaths that occur. And so, and that's not even with letting the blood sit that long. So I think that we just have to be very cautious and try to irradiate if possible before we're going to give the unit, as opposed to doing it and letting it sit. Many hospitals don't have irradiators. And they have to order them irradiated from their blood center, and then they have to let them sit. So there should be a discussion if you get past, let's say, 24 to 48 hours where it's been sitting there, about the patient you're deciding to give this unit to. What's going on with them? What's going on with their kidneys? Do they only have one line? Is the line only a central line and it's the tip of it's in their right atrium? I mean, there's a lot of things that should be thought about.
Absolutely. And Cassandra, let me just interject that for anyone listening, if you struggle at all with understanding the relationship of irradiation with preventing TAGVHD, I have about a 10-minute video on my website with some stupid, funny animations that kind of takes people through it, and you can find that on the Blood Bank Guy website. So just again, that's just a commercial. See, I threw in a commercial there.
It's good. I like it.
That's right. It is an infomercial, but it's free, so it's okay. All right, so let's move on and talk about CMV Safe, because I think that's a big deal that we need to talk about.
It's totally a big deal. And the one thing I want to say is irradiation does not get rid of CMV.
Yes. Say that again, Cassandra.
Irradiation does not get rid of CMV.
Oh, man. I get that question all the time.
Yeah. And so I want to lead in with that is a myth. And don't believe anybody who tells you that. So as we move on to this topic of CMV, the reason that it is hugely important in premature infants is that CMV in the early 80s killed a lot of babies. Mm-hmm. Okay? So this isn't like, oh, this is not a problem. This was a problem. And neonatologists are taught that this is a very big deal and that it all comes from the blood. And so the reason that neonatologists, if you practice in certain parts of the United States, the reason that neonatologists get all upset about things when we say, well, we only want to give leukoreduced products because they're CMV safe, is that they've been taught that CMV negative negative products are what they should give. And the reason is because that's what ended a lot of their problems in their babies in the late 80s. Is that by giving CMV negative blood from CMV negative donors, they reduced by 30% in many cases the transmission. So then we came along with leukoreduction, which really does a great job because CMV harbors itself after the primary infection in the donor or the person in the monocytes. And by leukoreducing, you can get rid of those if you get less than 1 million cells after leukoreduction. We feel as a community in blood banking that you have a CMV safe product. And so with that knowledge, there have been small studies in the 90s and a little bit in the late 80s with different filters than we have now in the 21st century that showed that there was promise in just giving leukoreduced products alone to these infants. But the studies were very small and the confidence intervals were very wide. So we just finished a study that was published in 2014, the end of 2014, that in JAMA Pediatrics that basically looked at this question of leukoreduction and CMV seronegative blood going to premature infants that weigh less than 1,500 grams. The docs would not let us randomize because they still wanted leukoreduction and CMV negative, which is what they normally get. We conducted this all in Atlanta at Northside Hospital, which is a private hospital, and Emory University. We enrolled about 539 babies. And 76% of those mothers, there were 462 mothers, were CMV positive. All the babies received leukoreduced and CMV seronegative platelets, red cells. We did NAT testing on all of the blood, 100% on all the units, both FFP, cryo, anything they got. We also did flow cytometry looking at residual white cells to make sure there were no leukoreduction failures. Because if you have a leukoreduction failure, then you're really not getting rid of CMV from maybe a CMV positive donor. And so we did that. And basically, we showed that with that strategy, there were 310 of those 539 babies that were transfused in this, so almost 60% transfusion. And we had zero transmission. And actually, we worked that out. It was less than 1% less than 1% risk of getting transfusion transmitted CMV. There were over 2,000 transfusions given. There were over 800 units given. Now, remember, we give small aliquots to babies, and we have dedicated units, so there weren't as many units as you would think with these 2,000 transfusions. The shocker, though, was we still had CMV in these babies. Okay, so almost 7% of the babies still had CMV. And we also tested all of the breast milk in all of the mothers. And and 27 of the 28 babies that got CMV, and 5 of those had disease, they all got it from the mother.
Wow.
Yep. And and they had very high, we're talking some of them at 100,000 international units per ml of CMV in their breast milk. And in the babies, they had, 9,000. There were very high numbers. And so, just like blood bankers are always, saying, well, there are other places you can get CMV. Well, this study kind of showed that, yeah. So the cumulative incidence at 12 weeks for CMV breast milk transmission was 15%. And so the neonatology community has been really concerned about this. And then I went on with Megan Delaney in Seattle, and we, at the same time we were doing this study, we embarked on another study, which was just published in Transfusion, this year, like 2016. It's ahead of public, EPUB ahead right now. Right. And we decided to look at leukoreduction only, CMV untested blood. Going into these babies, we did all the exact same setup that I just described for our study. And we enrolled 20 infants, and 8 of the kids got transfused, 43 transfusions, and 60% of the mothers had CMV positivity. None of the transfused units transmitted CMV, and 5 of the transfusions that occurred with these babies came from CMV positive blood donors. And there were no leukoreduction failures. We did all the same thing we did with the other study. And we had 1 baby who got CMV, and it was from breast milk. And so what we basically kind of pulled together with all of this for the neonatal world is that, yes, if you can get CMV seronegative and leukoreduced blood, then, that would be ideal, because we just showed that with the right, powered study. However, we know there are places that are only giving leukoreduced blood, and it's CMV untested. And we know that we're getting good yield, we're getting good filtration. And so the question still remains, is that if you gave blood from a CMV positive blood donor that was optimally leukoreduced, what is the transmission rate? We couldn't answer that with our study. And we think that we should have a comparative effectiveness study. And that's kind of what the discussion was in the Delaney paper, is that if we looked at 300 more babies where there was leukoreduction with CMV untested, and we did this exact same study, we probably could understand whether we could just go with leukoreduction alone, which is probably fine, because in our study, we had 1 leukoreduction failure, and it was by 1 cell, like literally. And so we feel that this is important, because as far as the industry goes, if we could stop doing CMV testing for this population, which in many places is demanding this, that could save an unbelievable amount of money. And anyway, so that's kind of where that goes. Now, when it comes to oncology patients, the jury's still not really out either, because even in the adult world, there's still controversy as to whether CMV safe leukoreduced blood, which is optimally leukoreduced, really doesn't transmit CMV. And so there's a lot of, people still want CMV negative. Some people do. And so we, for our pediatric patients, say that leukoreduction alone is safe, because we feel like the amount of reduction now is there's so few cells left that we feel that the transmission is almost nil. Whereas when those other studies were done in the late 90s, they still had 3rd generation leukoreduction filters. Yeah. It was really different than it is now. We wouldn't.
And I think a lot of bedside filtration.
Absolutely. There was quite a bit of bedside filtration, and there was a lot of crossover. It was hard to know. It was hard to keep everything straight in those studies. So I think that, I think it's easier to say that leukoreduction alone in CMV untested is okay for pediatric oncology and stem cell transplant patients. That's what we practice.
Excellent. Well, that is absolutely, you're 100% right. As you know, that is controversial, and there's I have really variable in my blood center practice. There's really varying opinions out there, not just in the pediatric world, but in the adult world as well, as you said. Yeah. So this is obviously something that more work needs to be done. But I appreciate the work that you've done with it, and especially I tell you when your article came out about the breast milk transmissions, I was like, somebody proved it. Yay! I know. I've been saying this for a while. It's somebody proved it. Yeah, it was awesome. So,
well, the nightmare is when they ask you for that look back. Go look back at all the units and see if you can figure out where the CMV came from. Now I just tell them, we'll test the breast milk.
Yeah, there you go. There you go.
All right.
Well, so we have cleaned house, I believe.
Yes.
That's outstanding.
Straight. Okay.
So let us move on to topic number 4, and this is a great one. I think this is one that there's definitely still some controversy about as well. We're picking the hot topics.
Absolutely.
So why don't you hit us with number 4?
Okay, so this is near and dear to my heart. It's an ounce of prevention makes red blood cell transfusion possible and life saving, and this is really in patients with sickle cell disease. And the reason I say that is, first of all, just so everybody gets a little background, around 100,000 patients. People in the United States have sickle cell disease, and it occurs in about 1 out of every 365 Blacks or African American births. It does happen in Hispanics. 1 in every 16,000 Hispanic Americans have sickle cell, and 1 in 13 Blacks or African American babies are born with sickle cell trait. So this is a big problem. And before I get to the prevention part, I want to just say that in sickle cell, there is not a lot of treatments. There's like 3 major treatments. Hydroxyurea is one, which lots of people hear about, and it's a drug, and it helps with decreasing some of the anemia. But really, the mainstay of therapy is transfusion and stem cell transplant. And the transplant where it's the best outcomes is for matched sibling transplants. And many, many children do not have a fully matched sibling. So there are allo transplants and, partial mismatches that are out there, but are matched unrelateds, but they don't do as well, and they still haven't figured out the best, the best scenario there. So really we're left with transfusion, and transfusion is used to treat not vaso-occlusive crisis. Nobody should be treating with transfusion, but for primary and secondary stroke, so primary stroke prevention, secondary stroke prevention, acute chest, splenic sequestration, there are many, many things, and they all start in childhood. So,
Cassandra, can I stop you for just 1 second? Because you just said something that I want to make sure that my audience doesn't miss, because the topic of treating sickle cell crisis with transfusion it's so commonly misunderstood that I know this is slightly off topic of where you want to go. Forgive me for that, but it's such a crucial point to make. Could you just spend half a minute on that?
Absolutely. Okay. So vaso-occlusive crisis is definitely going to drop the patient's hemoglobin. So many of these patients live with a hemoglobin around 7, 6.5. And when they get a crisis, they can go to 4.5, 5. And they still can maintain their oxygen level where they don't require oxygen, but they're in a pain crisis. And if we were to transfuse every time they have this, we might be able to raise their hemoglobin. It doesn't necessarily mean we're going to be able to change the crisis, the pain crisis natural history, but we are going to give them iron. And every time we're going to give them iron. And so there is no data to support the fact that during pain crisis, we should be giving this for acute vaso-occlusive crisis.
Preach it.
All right. But the thing that people get confused about is that acute chest, let's say, is a vaso-occlusive crisis in the chest, but it's causing a hypoxic problem. As soon as you get hypoxia, which is what we call symptomatic anemia in an anemic patient, because, these people don't feel good. I mean, they always don't feel as much energy and stuff like that, which is different kind of anemia than when you have a person who doesn't have a hemoglobinopathy. So you kind of have to distinguish that. But as soon as they develop that oxygen requirement, it can go downhill very, very quickly when they get a hemoglobin of 4 or whatever, and they're sickling there. And of course, if you're having that same process happen in your brain, bad news. So we want to turn that off as soon as possible. And so that's why we will transfuse. Splenic sequestration, same problem. They can just put all of their blood in their spleen, and they can just drop their blood pressure, and they can just die right in front of your face if they get a huge splenic sequestration. So it can kill them as well. So we've got all this transfusion being important. However, we have this balancing act with iron as a long-term problem that can kill the patient. But the shorter-term thing, which is not well understood, is why do some people develop antibodies to the red blood cells? And I'm talking about to the minor red blood cell antigens. So for, RH, CE, the KEL system, so for KEL, et cetera. That's what I'm talking about here. We know that about 25 to 30% of these patients will develop an antibody. And once they've developed an antibody, whether it's an alloantibody, which means to, a foreign, protein, or whether that, or it's an autoantibody to themselves, they are going to be at risk of developing even more antibodies. The problem we have is that we don't know which patient is at risk. And this is like the biggest problem we have. So in order to make everybody as safe as we can, we've developed strategies which are not the most practical, but they are not the most cost effective, but they are the most effective for what we have right now, which is to match beyond ABO and RHD. And we do that prophylactically. So we're doing it before they develop an antibody, even though we don't know which patients are going to be that developer. And so in sickle cell, comprehensive sickle cell centers in the United States, many places will test as soon as the person is born, basically, and they come to clinic. We will do what is called a phenotype on them. And we will look at some of the most clinically significant antigens on their red cells that if they developed an antibody to it, they, could be in trouble. And those are CE, KEL, Duffy, KID. But there are other clinically significant antibodies that I'm not mentioning, but those are the most common. And so that's what we do the phenotype on, are those first few that I mentioned. And those sit in many people's blood banks just there. And then if somebody comes in for an acute problem where they're going to need a transfusion, they can order blood from their blood center that will be antigen negative for the antigens that the person has, that they're antigen negative for, plus their ABO and RHD type. And so that's what many centers have kind of worked on. The issue is, and the NIH, by the way, has now endorsed, at least for CE and KEL, in their sickle cell guidelines, they say that you can match now prophylactically for CE and KEL. So that's a big step, because before that we didn't have anything except for like category 3 evidence, which is still what they use to put that in the guideline, but at least it's there to show that that's what we should be doing. Dr. Vyshinsky and colleagues in 2001, they showed that doing this matching actually reduced transfusion reactions by 90%, like delayed hemolytic transfusion reactions, and that their alloimmunization rates went from like 3% to 0.5% per unit. So that was a huge, big deal. So that's what we're basing the CE and KEL matching on. The issue of this discrepancy sort of, and I don't know, if this is too much information, but just that the donors who are out there who are supplying most of the blood, their ancestry is a little bit different than the recipients that we have in the United States. And that European versus African ancestry is why we get some of these mismatching if we were to just match for ABO and RH. And so we try very much to go to minority donors and have minority donor collections to be able to get more blood that is similar to the patients that we're treating. And so in the United States, in different states, they have different programs, Blue Tag programs, Partner for Life programs, all different, the Drew program in Washington, St. Louis. And so Washington University in St. Louis. And so there's all these different ways, but still that has not thwarted the entire alloimmunization process. And so what's on the horizon and what is actually now FDA approved, at least one of the tests are, is genotyping. So can we more cost effectively test more antigens than 7 or 8 with phenotyping, which is just looking at the protein on the outside of the red cell with an antibody and identifying it? Can we look at their genes and look at their DNA and look at their projected phenotype based on their genotype?
Right.
I hopefully said phenotype from their genotype. Anyway,
you got it.
And so what we found is with some of that genotyping, and Dr. Chow and Dr. Westhoff, who I know has done another one of your podcasts, looking at RH specifically, they found that there's still alloimmunization happening, especially in the RH part of the gene, and that has to do with the fact that when they went down and looked, there are actually variants within the E and the C antigens in the RH family. And those variants make it look like, if you only did it with an antibody and looked at the phenotype, they make it look like everybody's protein is the same. But really and truly, it's not. And these unfortunate patients develop antibodies and they end up that they can't get blood because they can only get these variant blood, and not everybody has these variants. And so what I'm trying to say is that this prophylaxis and things we're doing is helping some because it is getting these patients to adulthood and they can still be transfused, but we're not completely stopping alloimmunization. One of the things that just got published recently are 2 very important articles that people should look at. One was published this January in 2016, which was from our group, where we talked about the impact of red cell immunization on sickle cell disease mortality. So many people don't think about alloimmunization as causing people to die. I mean, if you get a transfusion of a unit that has a mismatch and you have an antibody, yes, you could have a hemolytic transfusion reaction and die. And sometimes we're forced, because there are so many antibodies that have developed, that we have to go to that and somebody could die.
Of course.
We also don't always remember that we can't always find antibodies that people have because they haven't gotten transfused in a while. And so they get transfused, have a delayed transfusion reaction because they didn't see it on the screen, and they can die from that. But the biggest thing that people miss out on, and this is reported, we have about 5 cases in here, is people waiting for blood. As we look around the United States, somebody has 6 antibodies and they need an exchange transfusion, they're having a stroke or they're having some big event. We can't get enough blood for them to do what we properly need to do because we didn't prevent alloimmunization when they were children. Now they're adolescents, they're adults, whatever. So that's actually happened, and it's been sad, and we kind of reported on those. But another thing that just came out this month in transfusion, I believe it's this month, but I think it's ahead. Yeah, it's ahead of print, I think, by Ballas and McLaughlin, is that it's called the high mortality among children with sickle cell anemia and overt stroke who discontinue blood transfusion after transition to an adult program. And so what I want to say about this is that some of these patients, they go to adulthood and they don't get transfused anymore for a myriad of reasons. Sometimes it's about antibodies. And they just say, you're just too difficult to transfuse. And what they're saying is people who have gotten started on transfusion for whatever the reason when they're children and they don't continue as adults, they're dying. No. And it's terrible. So we spend all this time and try to make them have a good quality of life and live for a long time. So I want to just bring that to everybody's attention, that prevention of alloimmunization will lead to more therapy and more possibilities for people when they become adults, which is what we strive to do for the children.
That's awesome. It's obviously it's a big topic, and there's a whole lot to say about it. And you did that. that was great. Amazing. Can I pull it back for just 1 second to ask you one question? And you mentioned the strategies in terms of the prophylactic matching. Is it, how would you characterize, and I know it's not universal. I know people have strong opinions about going the quote unquote full phenotype matching, but what is the most common thing that you're seeing out there in terms of how people match prophylactically? Is it that CE and big K, or is it
well, it's many places will start out with CE and big K. Okay. And that
for people that haven't made antibodies, right?
And if you've made an antibody, this is what we do. We have category 1 and category 2 is what we call them. Once you've made an antibody, then we'll match for that. We'll give you antigen negative units for that antibody plus CE and Cal, plus we'll go to Duffy A and JKB, whatever. And that's where we'll extend it to. And then sometimes we'll go to S. Big S. There is a really good immunohematology edition from the Red Cross. I think the last one was put out in 2012 or 2013. It summarizes at least 7 or 8 centers, how they do their prophylactic matching. And I can get we wrote it, Annie Winkler and I wrote our particular one, but I think Jerry Menny was the editor. But it's a really good resource. But I think they're, looking at Connie Westhoff and Stella Chow's data on this would be really helpful too, because that's linking the genotyping with the phenotyping and the prevention as well.
So you said something that I want to make sure the audience is aware of. So if those of you that are listening, if you're listening to this through iTunes or Stitcher Radio, you can go to the Blood Bank Guy website and go to the show page for this particular episode, which is bbguy.org/podcast, and you'll find it there. On the show page, Cassandra and I will work together to get a list of references for some of these articles that she's talked about, so you can look them up yourself and have them for your records, because it's really going to help you. It's going to help you going forward. So. All right. So that's a great topic, and I'd love to talk to you for another 25 minutes about that. But
got one more.
We got one more. I got one more. Okay, so let's just real quick before we do that. Number 1 was the volumes vary. Number 2, we were talking about the predicting the platelet effect, which is a surprisingly little effect in some of the patients that we've discussed today. Number 3 was cleaning house, a discussion about irradiation and CMV safe products. And then the last one, the ounce of prevention makes red cell transfusion possible and life-saving. And Cassandra, I have no doubt that number 5 is going to be just as great. So
thanks. So I'm going to just spend time on a look at hemolytic disease of the fetus and the newborn. I'm going to spend time on what it is. I'm not going to spend so much time on how we transfuse, because it's just such a big topic, unless you want to ask me some questions about that part. I think that's the way to go.
Well, I just might.
Okay, we'll see. All right. Well, we know that we have 2 different things going on here. We have hemolytic disease of the newborn, so that's when they're out of the womb, and then we have hemolytic disease of the fetus and newborn. And I think sometimes they get all kind of jumbled up. So let's talk a little bit about this. So first off is that when it happens to the fetus, it is something that the infant or the fetus is exposing the mom to, and the mom is going to make an antibody. And this antibody has to be of an IgG form. Otherwise, it won't cross the placenta. So it can't happen in the fetus if it doesn't cross the placenta. And so if it's the first sensitization, say to D, which we try to prevent that's anti-D is the worst, is that if the mom gets sensitized, sometimes the firstborn baby is not affected or very, very mildly affected, because that IgG has to have formed after the whole sensitization occurs. Sure. But the second baby can be affected and can be immensely affected. And basically, this can happen with D, little c, and Kel most often. Those are the most often ones that can cause hemolytic disease of the fetus. And around 20%, if it happens with D, are the ones that are seriously affected in utero. So not every baby is going to become hydropic and, just have all of and hydropic means where they're going to just have such severe anemia that they're just going to become edematous, go into cardiac failure, and die in utero. So those are the kinds that we are worried about in utero, and those are the ones that we give intrauterine transfusions for when we can detect it and, trying to save the baby and then have them come out. Then we have another type, which is ABO, hemolytic disease of the newborn. And that really isn't happening in the fetus. It's happening in the newborn because it's happening outside, once the baby's born. And it's happening with antibodies. They are, maybe can cross, they kind of cross, but they don't cross in the fetus. They cross a little bit in the fetus in the third trimester, but they don't cross big time like these other ones earlier on once the patient's been sensitized. So they don't come out super anemic. Okay, it's kind of right at the end that they come out a little bit where their DAT is positive and they can be somewhat anemic. But there is antibody that has crossed. It is usually IgG A, B. And it does cause this insidious hemolysis, usually in an O mom to an A or a B baby. And it's usually an O to an A that's the worst. And that's because of the antigens that are present on the red cells. There are more A antigens than B antigens. But usually what happens is after the baby's born, a DAT will be done and for a mother who's O. And if the DAT is negative, the expectation is that there's really not going to be a problem. If the DAT is positive, but the hemoglobin hasn't dropped, then there's still a little question of whether there's going to be a problem. But sometimes their baby, and they see the hemoglobin, which should be around 14 when they're born, can be around 10 or 9 or it's lower. And then they'll measure a total bilirubin and they'll see that is going up, and they'll put the patient on some phototherapy, which hopefully with eating and the phototherapy will take care of the bilirubin and get rid of it because you poop it out or you pee it out. With the reason that babies don't die with the hyperbilirubinemia in utero, just going back a little bit with the hyperbilirubinemia, is because the mothers are able to get rid of the bilirubin when they pee and everything. So it isn't until the baby's born where their system is overloaded and they can't deal with the conjugating of all the bilirubin and getting rid of it properly that you get this unconjugated hyperbilirubinemia. And if you start to get in the ranges of 17 to 20, I'm trying to think of, is it milligrams per deciliter? I think it is.
I believe it is.
I'd have to look to make sure. But if you get up into those ranges, that's where we start to entertain doing a double volume exchange transfusion on one of these babies. We hope that with phototherapy for the ABO hemolytic disease of the newborn, that you actually can prevent that, not get to that exchange. And then if they're for the babies that have had hemolytic disease of the fetus and newborn, so they have a minor antigen antibody, like the D or the Cal or any of those babies end up remaining anemic. Even when they've had intrauterine transfusions, they can remain anemic up to 6, 8, 12 weeks after they're born, even though they come to term when they're born. And that's because the antibodies from the mother really stay around for quite a while, 6, 8 weeks. Yep. And they actually have been shown in some instances to attack the erythropoietic progenitor cells. So your retic count remains very, very low in these babies. And so that's why they still continue to require transfusion after they're born. It's not exchange transfusion, but they require, they need to be monitored, and many of them require 2, 3, 4 transfusions post. And of course, they still should be antigen negative for all the things. Right. And then once that antibody has disappeared in those hemolytic disease of fetus and newborns, you can go back. They shouldn't need a transfusion. They should be just fine. But you don't have to worry because that antibody will be gone forever. It's not from the baby. It's from the mother. Right. And that's what people sometimes forget, is that those antibodies are eventually going to go away. It's just a matter of time.
Got it. So and what you mentioned about the nailing the precursor cells, that's kind of most famous with anti-Big K, right?
Yes, it is.
When I describe that to people and I talk about anti-big K HDFN, I typically will say it's not nearly as hemolytic as the other possibilities, but it's more of a suppressive type of phenomenon.
Absolutely.
Is that a fair way to put it, or am I overstating?
No, I think that's a fair way to put it. I also think that we're seeing more of the KEL. And I think it's all relative because we give prophylaxis for D. D was the most common and it was the most severe, but in the United States, people have prenatal care and they get what they're supposed to get. Then we've really thwarted the big one. And so KEL is the main one out there. We don't have any anti-KEL treatment,
right?
And or Kelgam or anything like that. And so and so if we did, then maybe we wouldn't even see that. But I do think there is a little different pathophysiology, like you're describing. There's more of a suppressive, and I'm not sure whether that just is the way the avidity or affinity of the antibody is for the antigen, or how soon that antigen is formed on the precursor. It might have something to do with that.
Maybe so. The other thing I wanted to ask you about was with the ABO form of hemolytic disease, as you said, primarily of the newborn rather than the fetus and newborn. What I found often in my interactions with clinicians about this is that most pediatricians are fairly attuned to this, and they're fairly well aware that this is something that can occur. And often I find that they're more aware of it certainly than some of my pathology residents sometimes. But is that a fair perception?
It's a totally fair perception. It's like the very first thing that we're taught. So when you're a pediatric resident, you always say, Duffy dies, kid kills. I mean, they really talk to us about this because we are in the nursery and we're seeing all these term babies. And so we will have these moms, and you'll have a list of all the babies you're going to do your physical exams on, and you're going to discharge them all.
Right.
And so you're looking for ABO incompatibility, you're looking for jaundice, you're looking for all those things because remember, people aren't staying in the hospital, so you're going to have to set those bilirubin lights up and do all that phototherapy. The other thing is that we have the moms that are O's, and we're always like, oh, this is a setup. We always know the mother's blood type, and then we're looking to see what the baby's blood type is, and then we look at the DAT. So we really are. It's kind of drilled into us to do all of that. So that's why we're aware of it.
Good. Then that's a good thing.
A clinical person knowing something about blood banking.
It's outstanding. I know. Yes. All right. Anything else on that, or was that the main
thing? The only other thing I want to mention about this is that when you have a baby who's pretty sick, and at the children's hospital, we don't always have the moms, but the moms sometimes will come because that's not where the babies are born at the children's hospital, or at least our children's hospital. CHOP has a maternal ward, but sometimes when you're working on these specimens for these babies and you need more specimen for their screen, or you're still trying to delineate what's going on, people need to remember that they can get blood from the mother, that they can work on the specimen that way, and that they don't have to keep bleeding these babies. So they don't have to get all bent out of shape when we call and say we need more specimen. We really should be thinking clearly about where did this antibody come from, and if we need more to work with, then we need to ask the mother to give us some blood.
Great point. That is such a great point. Bleeding a baby to anemia or further anemia in the face of this is just it's dumb, isn't it?
And nurses have a spaz on the blood bank. I mean, the medical technologists get yelled at. You want another specimen? Oh my God!
Yeah. Well, thank God for the nurses in that case, right? My goodness.
There. Yeah, very protected.
Absolutely. My wife, by the way, I'm sharing something I've never shared publicly. My wife, at one point, was a NICU nurse, and she used to tell me all the time that just drove her crazy when the blood bank wanted more specimens. She's like, "Stop it! No more."
No, it's still that way, and the babies are even smaller.
Yep. Yeah. All right. Well, so we have made a grand tour through a bunch of really cool stuff, cool. Cassandra. I can't tell you how much I appreciate this. I would love at some point to have you on again to talk about some things that we haven't been able to discuss, some controversial stuff like, age of blood we haven't gotten to, and I know you've done a lot of work on that. And another one that I know you're working on right now is the association of necrotizing enterocolitis with transfusion.
Absolutely.
So we've got there's some more stuff that we can talk about down the line if I can twist your arm and talk you into coming back onto the podcast.
Well, I first of all, I'm really honored that you asked me. I enjoy this, and I would love to come back. Yeah, there are so many things. Pediatric transfusion medicine is that interesting and that cool. You should go into it. That cool. Yeah.
Yes. All right. Well, we're gonna close it for now then. Cassandra, again, thank you so very much.
Talk to you soon.
Hi, it's Joe with a couple of quick closing thoughts. Thank you again for listening to this podcast. It was a longer one than usual, but Dr. Josephson just had so much excellent stuff to share that I hope it was useful to you. I'm sure that it was. Again, a reminder, the next time you're on iTunes, please give us a rating and a review and subscribe to the podcast. That really helps me get it in front of more people. Thank you again for listening. Thank you again for being here and for supporting this podcast. I can't tell you how much I appreciate the emails and the Facebook messages that I've gotten about the podcast. So again, I want to remind you one more time, as you go through your day, I hope that you smile. I hope that you have fun. And above all, never, ever stop learning. Thanks very much, and we'll catch you next time on the podcast.